Welcome.
Thank you. Thank you, Lonnie.
So, Ken, if you don't mind, it's always a pleasure to talk to you. And I've had many chances to get to know you over the years, and we've done a lot of things together because we've both been here now a long time. But I like to get a sense for people who have done as much as you've done. You've trained in outstanding institutions around the world. You're known on a global stage for what you do in pediatric ophthalmology, and you're so highly regarded. But at some point in your young career, or young life before school, maybe, you decided to get into medicine and science. Tell us what was the motivating factor.
So I think if I go back, I think there was a pivotal moment in my life where I couldn't decide whether I wanted to do law or whether I wanted to do medicine. And my interest in science was very much the fact that, I loved the fact that you could work out how a body, whether it was an animal's or a human being's, worked and how you could fix it. That was a real fascination for me. I think I got into law because of all the American series I used to watch. There was this show called Petrocelli. I don't know if you ever remembered it, but it was huge in Europe.
I don't even remember
it. It was really glamorous, And so there was that, I'm of that generation where you sat down with your parents and said, I'm thinking of doing this or that. Mm-hmm. And the pivotal moment was when my mother said, "You're going to be a doctor," and I said, "Fine." that's that decided for me. But I already had a fascination. So really, that was about 11 or 12 that I had. And to be fair, I remember going into school and thinking, "Yeah, I really got to concentrate on science now because I enjoy it, and now I'm really going to go deep dive into it."
Oh, that's the first time someone said, "Oh, my mother told me I'm going to do that." So now your patients benefit greatly from the care that you provide, and you're caring for children and who I know that your work in cornea transplant and other things is certainly well known. So share with us some of the things that you're doing both clinically and in research that are happening right now that our viewers would want to hear a little bit more about.
I think one of the things that I've come to realize, Lonnie, is that while I have this overriding passion to cure childhood blindness, and I know that sounds like an extraordinarily huge task, but if you don't, in my opinion, if you don't clearly have in your mind what your target is, whether you achieve it yourself in your lifetime or whether the teams that you create and the programs of clinical research and clinical delivery that you develop, if you don't achieve it in your own lifetime, you can certainly set the motion in that direction. So that's my overarching goal. In my personal interest is children who are born with problems with the front of their eye. So the cornea, which is the window of the eye, lenses, children get cataracts, mm-hmm. And glaucoma. And when children get glaucoma, it can be devastating if it's not dealt with appropriately. So if we think about my own interests, what I've done, and I've been very fortunate, which is one of the reasons why I came to Pittsburgh, was this conglomeration of fantastic universities, Pitt, CMU, and UPMC itself. Mm-hmm. If you look at what I've done is I've managed to create a team of dedicated genetic counselors, a dedicated molecular biologist, Paresh Chauhan, a dedicated pediatric electrophysiologist, and we are now have delved for the last 10 years into defining a deep phenotype. And what I mean by that is this. It's almost incomprehensible, but what I'm about to say is true. Until we started working on this about 15 to 20 years ago, a child could be born with an opaque cornea, and no matter what the cause was, they would get this diagnosis of something called Peters anomaly. And it's a bit like saying a cough is a diagnosis.
Okay.
You and I know a cough is not a diagnosis, but this sign was being given the name Peters anomaly, and people were thinking it was a diagnosis. And what we've done is we've created a deep phenotype, and by separating all the different causes, it's allowed therapies and it's allowed investigations and work with lots of people. So I'm working with Nathan Clark, who was at Pitt. He's moved now, but we continue our collaboration in working out what the causes are. I work with Baresh Chauhan.
Mm-hmm.
But the other thing is, and I guess this is perhaps a reflection of my need as a surgeon to do something in the here and now, we've developed surgical innovations and then also pharmacological innovations. You know, I work with Morgan Fedichuk to develop delivery systems so that we can help children who have other types of corneal problems. So it sometimes looks, when I'm asked to talk, like I'm doing lots of different things. I'm not really. I have one thing that I've learned is, if you can work with people and give them information and give them advice and your experience, they often have their own area of interest, like I have, that can complement my overall goal. So I think I would say that people would consider me as a collaborator, but I have an invested interest in anterior segment problems in children.
Well, you know, that's essentially just also really good management and you know, delegation of responsibilities. But you do have an amazing team, and learning about what everybody's doing, and particularly into the deep phenotyping and the genetics is very exciting. I know that you were going to tell us a little bit about that, some of the work that you're doing, and you had some slides you wanted to bring in. So please do.
Thank you. So one of the things I wanted to share with everybody is this is something that I'm very lucky that I've managed to get all of my division to buy into, and that is the child first and always. Because I think if you have that, you really cannot let your patient down if you have that as your mantra. And I'm just going to forward this, just to make sure I'm on the right. There we go. So this is something I'd like to talk through. You know, I've put clinical care at the very top there. That's the most important thing that I do as a clinician. But what happens is that when you do a really good job at clinical care, and I do that by having my whole team create protocols and then measure what our outcomes are, you start to get patient cohorts coming in that have similar diagnoses. And that leads to a clinical question often. And that's where the translational research comes in. Because translational research, often people think about from the bench to the clinic. Well, we take it from the clinic to the bench to answer questions so that we can improve our outcomes and our therapies. But you can only do that through collaborations. There's no point me having my own lab. I'm a clinician. I love being with patients. But the experience that I've gathered allows me to work with excellent scientists, basic scientists, to collaborate and develop not only devices, but also therapies. And then the other important thing is education. Because if it's almost like a perpetual motion circle. When everything starts to lock into each other, that's where the whole process moves forward. And I've been fortunate that at Children's Hospital of Pittsburgh, and with the support of Jose Sahel now, and prior to that Joel Schumann, I've been able to get this thing going. But I think what I learned, what Jose Sahel's brought, is the idea that you have to have investment, not just from research sources, but from the device development, where you can, working with people, develop startups to help propagate what you're doing. And what I'm showing here is a picture of a work on some of the children with corneal opacities, and the pictures at the top are in an animal, in a mouse model, showing how the eye develops. And what I'm showing here is that the development has been abnormal. This picture here shows the early lens development and the cornea. Of course, they're supposed to separate, but I have children where the lens is attached to the cornea.
Oh.
So to be able to take that human example, pardon me, and work on it, that really helps the basic scientist, because we've got human correlates to tell them what's going on. And the other thing is, I do work on rare diseases. You know, 30 million Americans are affected by rare diseases. 30 million.
Wow.
2/3 of Americans affected by a rare disease are children. 20 million children. I find it difficult when I go to the NIH and I say I've got this rare disease that I think I have a therapy for. They say to me, well, it's a rare disease. It's not going to affect enough people. 20 million children. Now, they don't all have the same rare disease, obviously. But rare diseases are actually quite a good way of developing products, because the FDA has much lower thresholds because there's nothing else that can be done. And if you give them a therapy that is based in science and they can see it makes sense, you can get an orphanet route for your therapies, which means that some of these therapies may go on in the future to help other children and other adults, but you start off at a rare disease level. And that's where, you know, this is where philanthropy is so important, because without that philanthropy, these rare diseases don't get the attention that they need. And I'm going to quote a very old, 12th century Persian philosopher, Sadi, who said, "Have patience. All things are difficult before they become easy." And what I love about working here and working with you, Lawny, especially, is you help us make things become easy. So I really want to thank everybody who's listening to this. And this picture is, this girl was born with corneas that were opaque like this.
Wow.
I operated on her, and there she is over here. This was when she was 13. She wrote me a letter at 19. She went to university. This was 2 years ago, and just said, "Thank you for giving me that opportunity." This is a rare disease. But I don't know what impact. I know I had an impact on her life. I wonder what impact she'll have on other lives.
Yeah, that's what a wonderful thing to be able to do, and congratulations for having, the ability to do that, the passion to do what you do, but also, what a wonderful feeling whenever you help a kid like that really changes their lives. So, wow, it was good to hear that you're able to from the clinic have a problem and be able to come to the research teams and help solve that. Has that become, at all easier as we've really grown our research teams and have resources that are very widespread?
No, I think it has become easier. Obviously, I'm based at Children's Hospital, and so I'm a bit remote. But the new building, the new Institute of Vision and Rehabilitation, the vision of having researchers and clinicians, right next to each other, I think that will be formidable. Really will be formidable. Right. I'm jealous because I won't be there all the time, but I hope that when I am there, in an administrative capacity, that I'll be able to engender collaboration. I think people who want to collaborate. As you know, I've been here 8-9 years now, and the first translational research I did with Kira Lathrop. I've done it with Morgan Fedichuk. I've done it with Nathan Clark. I've done it with the people at Pitt who I would never see ordinarily. And I think that this era that we're in now, where we've come to accept that a conversation like this can be just as meaningful as, you know, seeing you, having a cup of coffee with you.
Right.
As this era develops and we find a hybrid, then I think there'll be more collaborations, because this is nice, and watching people's faces is so important. You know, those subliminal clues, you know?
Yeah. You know, you've done so much. I'm going to, if you were to point to one thing that stands out to you that really you're most proud of in your professional, you know, now, you know, long professional career, what would really stand out to you as the thing you're most proud of?
I think that's the most difficult question somebody has ever asked me, and I'll tell you why. Because there's a part of me who's an educator, and I'm extremely proud of the fellows I've trained. I've now trained 104 fellows.
Wow.
At Great Ormond Street, we had 4 a year, and we used to have 2 observers. And I was there 12 years. And I've been here, and every year, I've had at least 10 international observers who've been with us for 2 months, and we've had 2 full-time fellows, and we've had clinical research fellows. I can't tell you the amount of pride when I go to a country like Malaysia and my fellow is the head of the Pediatric Ophthalmology Society there and is thanking me for what I did for him. That's tremendous. For me, that is tremendous. I was fortunate to set up a charity called the World Society of Pediatric Ophthalmology and Strabismus with David Granite, who's in San Diego. And we completely shifted the paradigm of that, how societies work. Nobody has to pay us a penny to become a member. And it means that we have 3,000 members now, many in places in the world where there's no teaching or training for pediatric ophthalmology. And our mantra was expertise, no matter who you are, resides all over the world. And what I mean by that is there are people who do surgeries with 1/10 of the facilities that I have and still look after the children that they have to look after and do a really good job. And so we exchange ideas, we have webinars, we have a website, we have grants. We just published the largest study ever on a rare disease in America. The largest study so far on this condition was 119 patients. It took 19 years to get these. In India, by making 5 centers collaborate all over India, we had 532 children in 6 months.
Wow, that's powerful.
It's powerful because this condition is where children are born with no eyes or very small eyes. Now that we have 532 children, the International Genetics Council from the World Health Organization, having seen this paper published, have approached us and said, we want to do the genetic testing on these children, and we have the funding. That really changes. It's not only public health, it adds to the basic knowledge of medicine. So if you ask me what I was the proudest of, I guess those two would be vying for that position.
Well, you know, you should be proud. There's many things I know that you should be proud of, but we're proud to have you in Pittsburgh. And I remember when you came, and it was exciting when you came, and it's still exciting every time I get to talk to you. So, you know, thank you for spending time with those who would, you know, again, come and join us. I think this is nicer than just being able to read a bio about you. People get to actually hear you and see you and get to know how exciting you are as the rest of us do.
Thank you.
So thank you so much. And you have a long day ahead of you, so I'll let you get back to your work. All right. Thank you.
I appreciate you. Thank you very much.